Okay, so today what we're going to do is we're going to cover pediatric endocrine. This is a pretty quick lecture, but lots of material, and a lot of these endocrine pathologies use a lot of feedback mechanisms. So we'll talk about some of those. The best way to do this is to really understand how these work rather than try and memorize them. All right. Yeah, we know that guy. Okay, outline. So we'll talk about some thyroid diseases, a little bit of the theory and the physiology behind thyroid diseases, growth and evaluation of particular short stature, as well as deviations in growth, and when we want to refer to an endocrinologist, puberty, variations and disorders, puberty based, and this would be specific for the pediatric population, obviously, and then glucose regulation, i.e. type 1 and type 2 diabetes, as well as some hypoglycemia kind of topics and some things you need to investigate with hypoglycemia, particularly in newborns, and then hypocalcemia and some calcium physiology. The goal is really, as far as a clinician goal would be, to be able to understand when things are abnormal and most likely out of the scope of primary care, and allow us to then refer to an endocrinologist for evaluation or get a consultation with one. Vocabulary terms for endocrinology. So endocrine basically is related to glands that secrete hormones or other products directly into the blood. A paracrine gland secretes hormones that inhibit or stimulate nearby cells and tissues. Autocrine is a type of hormone that affects the same cell, tissue line, or type as the cells that produce it. And ogen is a suffix which refers to an inactive form of a substance, with an example here of trypsinogen. So it's important to just kind of review some of this basic physiology. We've got different hormone types that are active within the endocrine system as well as the rest of the body. We've got peptide hormones, which are derived from amino acids and can create, if folded correctly, structures such as proteins. You've also got steroids, which are a main backbone for a lot of compounds. Also, cholesterol is the primary backbone for these steroids. And then you have amine groups, which any amine group is going to have these nitrate groups that come off the bottom there. All right, so feedback is a really important mechanism, particularly with endocrinology. That's also why endocrinology drives most people batty, is this feedback. But if you really understand feedback and you understand the material rather than memorize the material, it really does start to make more sense. So the definition of feedback is that there's these changes in the environment, either local or global, and then the response. So an example of this is the hypothalamic pituitary control, where you've got this positive and negative feedback controlling the flow of information. When we talk about growth disturbances, we need to understand that from a pediatric perspective, this is the most common problem that ends a child up in a pediatric endocrinologist's office, meaning that it's usually the growth or some other complaint that brings the child in, and that gives us a cue that we may have an endocrinopathy and therefore refer. When we're talking about normal in a population of people, particularly a pediatric population, really any population, we want to think about what is pathologic. So normal has a wide range, and what we have to realize is that sometimes people will live on the outlying ends of that range. Height velocity. Height velocity is actually the most critical metric for predicting some sort of abnormality or pathology, particularly in endocrinopathy. This is difficult to do at less than 2 years of age, as the variability of length at these ages is very vast, but later on we have a little bit more of a tighter range, so abnormalities might be easier to find. The hypothalamic anterior pituitary axis. So it sounds really big and daunting, but it really is not. So if we break it down, we've just got that hypothalamus and the anterior pituitary and how those two interact with each other. We'll define again this another term. So we've got trophin, which equals to stimulate. So these tropins are usually stimulating something to occur. You always want to use age-appropriate ranges for hormone levels, as they are going to fluctuate, particularly with pediatric population. All right, so let's look here. So let me get my little pointer out. So all these releasing hormone, you see a lot of this releasing hormone, for the most part trigger the anterior pituitary. So this is our hypothalamus here. And then we've got the anterior pituitary here, also known as the ant pit, and the posterior pituitary, obviously, here. So in the anterior pituitary, we make certain hormones that are stored and then released at the call of the hypothalamus. So when the hypothalamus releases hormone to trigger the release, that's the control mechanism that causes the release of these hormones that are stored in the anterior pituitary. It's important to understand which hormones are stored in the anterior pituitary, and there's an easy mnemonic for that, which is flat. Pig. With no I. So there's no I here, right? So a flat pig with no I, and that's FSH, LH, ACTH, TSH, prolactin, and growth hormone. So a great way to kind of easily memorize those anterior pituitary hormones. The main thing is that, you know, this hypothalamic pituitary axis sounds daunting, but it's really not. Basically, you have releasing hormone, triggers the release of other hormone that's stored in the anterior pituitary. The more complicated part is what these actually do when they get to the tissues that they are targeting. So here with ACTH, we can see adrenocorticotropic hormone. So what that means, it's going to target the adrenal gland, particularly at the cortex, and it's going to release cortisol. So cortisol is the stress hormone. It's going to increase metabolism in the cell, and it helps to regulate cell function and trigger other cascades of reactions in response to stress. TSH, so just like it says, it's the thyroid stimulating hormone, which stimulates the thyroid, gets the thyroid all worked up to release T3 and T4. And T3 and T4 then control your metabolic basal rate. Also secreted from the anterior pituitary are luteinizing hormone and FSH, which both work in the reproductive organs. And this doesn't have to be super belabored or fragmented at this time, as it's out of the scope. However, we should know the basics, that these are going to trigger testosterone release, spermatogenesis, and secondary characteristics in a male, as well as estradiol, progesterone, and inhibin in the female as well to trigger ovulation and secondary sexual characteristics. When we're talking about prolactin, this triggers milk letdown. And then growth hormone is going to do a lot of different things, but particularly in the liver, it's going to control the release of insulin growth factor 1, which will trigger a lot of different cascades, one being a growth in linear and organ growth as well. So it causes organs to grow and the bones to elongate. So simplified is that you've got the hypothalamus, which is going to either be stimulated or inhibited by these particular triggers here. Then you've got the anterior pituitary, which is going to dump those hormones out, and then they'll be received by a target gland. So if it's a protein hormone and a steroid hormone, they are both going to be involved in this process. Protein hormone will attach to the cell's surface, that's the key, and stimulate the cell to change and do different things. That hormone can also feed back to the hypothalamus and cause deregulation of the compounds that are upregulating its production. Same thing with a steroid hormone as far as the negative feedback goes. However, if you see here, these steroids are small enough and agile enough that they can attach to the cell nucleus and then stimulate DNA. So interesting kind of nuance there. Here's a little bit more just to belabor this hypothalamic pituitary thyroid axis. Now we will talk about this. It's not much different, but you've got in the hypothalamus, you've got thyroid releasing hormone, which causes the anterior pituitary to secrete thyroid stimulating hormone, which stimulates the thyroid to produce the metabolites of T4 and then T3. These stimulate muscle and liver to do certain work for the body, and in turn, these two compounds or hormones feed back to the hypothalamus to trigger it to decrease release of thyroid releasing hormone, therefore decreasing release of TSH, and therefore decreasing the production of these hormones. Very interesting to think that that's a mechanism that you need to know and is actually fairly important. So let's just kind of talk about this in words. So the hypothalamus and pituitary, there's thyroid releasing hormone, thyroid stimulating hormone, which is called thyrotropin, TSH, TRH. See the difference? At the thyroid gland, tyrosine and iodine get together and form thyroxine, as well as T3, which is called triiodothyronine. In the serum, then, this thyroxine binding globulin, so this is the car that is going to transport T3 and T4 wherever it needs to go. And so that's why we want to monitor these, because if there's not enough of those, then you can't transport T3 and T4 very well. All right, so I guess you got a big. Let's cover them up. We got to tarp this because it's going to the dump, so we don't want to get in trouble for not having our cargo covered. All right, so 50 times more T4 is released into the blood than T3. That's a lot of the reason that we monitor T4. T4 is also the active metabolite. Oh, I just lied. Look at this. In the peripheral tissue, T3. So sorry, that is my bad. So, okay, so what we do is let's kind of regroup here and make sure that we've got this. So here you go. I even misspoke. Like I said, a lot of this is not greatly understood by everybody except these endocrinologists. However, we should have a good handle on it. So here you've got T3 as the active hormone. So most of this is in the form of T4 until it's converted to T3. So there's this conversion, and now this is your actual active hormone. So I had got that one wrong on the boards, but you guys will get it right. So T3 is the active hormone, Mr. Osink. All right, thyroid tests. So there's a variety of different thyroid tests. Very daunting to the initial clinician. However, if you understand what they do and you understand the mechanisms, it makes them a little bit less concerning. So we got thyroid stimulating hormone, usually ordered as just a screening test. If the thyroid stimulating hormone is normal, then largely we don't have a problem. There may be some nuance to that, but mostly we're out of the woods. We can also do free T4, which means it's not bound to that albumin car, or I guess it's not albumin, but a protein car, shuttle, if you will. Total T4 includes T4 that's bound to proteins and the T4 that's free. So if you want to get it, usually we do a free T4 and a total T4. And then TBG is this thyroxine binding globulin. So we can measure how many cars we have. We can measure how many passengers we have in the car. And we can also measure how many passengers are out here away from the car. Right? So this would be TBG. This is bound T4. Okay. And then we've got free T4. And we can see if we say total, this is total T4, right? So free, bound, and then total, free plus bound. All right. Or we could just also look at just how many of this there are. We can do an ultrasound if we're concerned and we want to check the anatomy of perfusion. We can also do a thyroid nuclear scan to assess function. This newborn screening exam, we've kind of talked about this over different lectures. This is not a lecture on that, but it is important to know that this is one of the tests that they look for, to look for thyroid abnormalities, because early on, if the thyroid is not working properly, we can have some intellectual problems. So it's going to look at TSH, T4, and T3. These should all be made in utero. At birth, the thyroid stimulating hormone should really surge, and then followed by that, the T4 should increase as the child no longer has exogenous sources of T3 and T4, right? So mom's got T3 and T4 circulating. The infant doesn't have to make them as much, so when they're born, the T3 and T4 levels drastically drop, triggering that feedback at the hypothalamus to make more thyroid-releasing hormone, triggering then the anterior pituitary to release this surge of TSH, which then triggers the thyroid to release more T4. So we want to do this initial screening for TSH levels at 18 to 48 hours of birth, and then repeat again at 7 to 14 days. That's how all of these PKU tests go. One of the main reasons we do that is we want to catch this early so that we don't have any developmental delay, and that's the big issue there. So congenital hypothyroidism, usually there's no symptoms at birth because at birth they're born with mom's T3 and T4, and then which the active metabolite is 3, right? Don't forget that like I did. At any rate, they start with this T3 and T4 for mom, but eventually that's going to tail off, and then they'll start having symptoms. So Early symptoms include decreased activity, tone, and temperature, prolonged jaundice, large fontanelles, puffy hands, protuberant abdomen. So they really swell up. They're like in this myxedema from the start, which would suck. They've got later on type of signs or symptoms would be poor growth, lethargy, molting of the skin, difficulty breathing, edema, umbilical herniation, and developmental delay. And that's what we really want to prevent with these kiddos. Take a quick break on congenital hypothyroidism, and we'll be right back. Okay, so continuing on congenital hypothyroidism. So if we are concerned, we'll screen. The confirmatory tests for congenital hypothyroidism include blank and blank. And we'll begin them with levothyroxine as soon as diagnosed so that we prevent or decrease the likelihood of an early brain injury, which can be irreversible. Further workup to determine if we have an absent or ectopic thyroid gland. Think about what test this is. And then others, we may see on physical exam a goiter or some sort of defect in synthesis. Maternal antithyroid medications may also be utilized or may be causing part of the problem. In this case, that would cause a abnormality of the thyroid and cause hypothyroidism if either the mother is taking antithyroid meds or she is making an antithyroid antibody, or severe iodine deficiency. If you've got severe iodine deficiency, you're most likely maybe going to see this goiter. All right. So ectopic thyroid glands are detected utilizing these fluorescent markers and radiology. So basically what we do is we do a nuclear scan and we want to see where this thyroid tissue lives. And if it's ectopic, meaning not where it should be, it'll light up somewhere different. So in this case, you can see some similar tissue down here in the pancreas. And if there's any ectopic tissue here's a marker of thyroid tissue out of the chin. All right, so congenital hypothyroidism, here's the diagnostic algorithm. So newborn screening for hypothyroidism, and the initial T4 is less than 10% with a high TSH, or they've got an initially high TSH. Or based on physical exam, you have a clinical suspicion of hypothyroidism. We want to measure the serum TSH, free T4 and T3 levels. If the TSH is elevated and the free T4 is decreased, we can confirm that this is a congenital hypothyroidism. If the TSH is low or normal and the free T4 is low, then we can diagnose them with likely central hypothyroidism. So these are just ways to try and figure out which type we're dealing with. Are we dealing with primary or central? The difference being that it is either the lack of brain response to negative feedback or positive feedback, and or it is due to a glandular deficiency. So if we're worried about a glandular deficiency, we can do a radionucleotide uptake scan or an ultrasound. We can also check their serum thyroglobulin and any maternal antithyroid antibodies. We can also check the iodine in the urine. If we're concerned about central cause, we can evaluate for other pituitary hormone deficiencies. We can MR the brain to see if there's an abnormality there, and we can check an eye exam for any optic nerve hypoplasia, which would be consistent with a central hypothyroidism, or if that is causing pressure onto the pituitary, inhibiting its behavior. Acquired hypothyroidism, so the symptoms would be poor growth, cold intolerance, dry skin, coarse hair, constipation, weakness, and goiter. Most common in the US for this particular acquired deficiency is Hashimoto's thyroiditis. Most common worldwide would be iodine deficiency. 2 billion people with preventable intellectual disabilities are prevalent worldwide. Childhood hypothyroidism is often not identified unless we are really consistent with our growth chart measurements. As you can see, this gal was off of the growth charts since she was 11. However, did not become diagnosed with hypothyroidism until she was 15. So 4 years went by where this could have been treated and diagnosed earlier, causing less problems in the body. See that poor linear growth right there. Hashimoto's or lymphocytic thyroiditis, basically the body attacks itself. It's an autoimmune disorder, peaks in adolescence, and is greater in females than males. They're going to have an increased thyroid stimulating hormone. And they're also going to have antibodies to antithyroid peroxidase. So they'll have antibodies called antithyroid peroxidase antibodies. There's a lot of antis, or antithyroglobulin antibodies. In any case, usually this is triggered by an infectious process. They develop this immune response that then is specific enough to target the tissue in the thyroid, or the peroxidase itself, or the thyroglobulin itself, causing the inability of the thyroid gland to produce the precursors for these, and then also causing an increase in the production of T3 and T4, therefore causing inflammation of the thyroid gland or inability of the thyroid gland to function. So what I'm trying to get at is, initially you may see a peak in these levels and then a sharp decrease. We want to monitor the TSH and the T4. We can biopsy or scan if we absolutely have to, however, not normally necessary. And then we're going to replace that T4 in the form of levothyroxine. What other autoimmune disorders may be associated with Hashimoto's thyroiditis? Well, if you just spit out any autoimmune condition, you could pretty much be close or right. Hashimoto's is associated with lots of different autoimmune conditions, particularly diabetes. Things you should know about Hashimoto's disease: well, genetics are a risk factor. Women are at higher risk. Excess iodine in the body can trigger this disease, but the most common cause is from radiation exposure. Symptoms include fatigue, mild weight gain, weak and brittle nails, constipation, and fertility problems. Complications related to Hashimoto's disease include heart problems, high cholesterol, anemia. That is a giant goiter. Jeez Louise. Yeah, I would say that's a goiter. And then birth defects if it's a pregnant female. Here's a case of asthma. So an 11-year-old girl with a history of asthma comes to your office with shortness of breath, chest pain, and increased use of her albuterol inhaler for the past 2 weeks. On physical exam, her blood pressure is 135/63 with a heart rate of 108. She appears jumpy, anxious, and has a tremor of her extremities and tongue. In her neck, you notice a diffusely enlarged goiter from the doorway and a bruit. What are you dealing with here? You're probably dealing with a severe case of Graves' disease or hyperthyroidism. We really use these fairly interchangeably. Rarely this is congenital, but may have some link to maternal autoantibodies crossing the placenta. 95% of childhood hyperthyroidism is caused by Graves, and that's why this is used very interchangeably. Obviously, it's an autoimmune disorder. Peaks in adolescence, more severe in younger children, and girls are much more likely to get it than boys. Continued on Graves' disease. So this gal, you can see that goiter. You can also see in her, I don't know, maybe you could convince yourself of some lid lag. I'm not sure that I see it. It's probably going to be seen when she's actively opening and closing, and then maybe a little bit of proptosis, which means the eyeballs are bugging out a little bit. This gal, it's not really prevalent, but I guess it could be possible. You'd probably have to have seen her when she was younger, but it doesn't look like really freaky. Some of those you see, their eyes just bug out. It's kind of crazy looking. So it may also be gradual at the onset. Graves' disease, it's not like one day they're just gonna go nuts. It kind of takes time. The signs and symptoms kind of are these vagology type symptoms, but difficulty concentrating, nervousness, disrupted sleep, accelerated growth, emotional lability, lid lag, tremor, and goiter. So the problem is that this lid lag, tremor, and goiter usually are presenting late. So these kind of vague symptoms present earlier, which makes it difficult to diagnose. In the labs, you can do a TSH and a free T4. You should completely understand how these are going to be affected. If you do not understand that, you need to be able to answer that. And you need to be able to diagnose the TSH receptor antibody positive. So if they've got a positive TSH receptor antibody, then you can, with good comfort, ensure that this is most likely Graves. And if you need, you can also do a nuclear scan or a ultrasound. So continue on Graves' disease. The first thing that we need to do is block thyroid hormone synthesis back to a normal level. So the medications for these that we use are methimazole and PPT. I'm not even going to try. Which have methimazole has a better safety profile, particularly in early pregnancy. So normally you'll see that. And then this PPT also has a risk for liver toxicity. So we want to monitor LFTs while the patient's taking this medication. We'll assess for remission after 2 years. There's a 25% remission rate. And if this is just one of those cases, it's not going to get better with medications, and we need to just really get aggressive, then you can do radioactive iodine therapy, which can induce permanent hypothyroidism. So that would be a conversation with your doctor to figure that out. And then surgery is also an option, which is a preferred second line if you're less than 5 years old. All right, so let's get back to the case. So this particular patient has a TSH of less than 0.01 with a free T4 of 7.8. Now, we're really going to confirm this. We would also say they've got antibodies to the thyroid. That's the thyroid antibody. And that is the diagnosis for Graves' disease. Yeah, that's a thyroid antibody, by the way. That guy's gonna go get. And this is the thyroid. I'm sorry. I'm lonely and I'm making myself laugh. All right, with methimazole treatment, the symptoms improved, including the asthma symptoms. Woo! We fixed the patient. All right, so what is normal growth? We need to accurately measure. We've seen these growth charts a million times. We see this stadiometer. There's no N in there, but I want to call it a standiometer as that kid is standing. So short stature, we want to investigate for short stature. We need to know if this is familial short stature, which you can see here. It's this nice kind of constant curve. Also here, or if this is a deviation. Is this a true deviation? This looks like a constitutional growth delay, so maybe something was going on or just genetically this child did go off, but then veered back. That's considered a constitutional growth delay, may have been triggered by a illness or something like that. So bottom line is we just need to investigate when we see abnormalities. If we'd like to calculate a suspected height, which I don't know, I think it's kind of fun, and I think patients think it's cool too. So this is a cool little calculation for that. So you guys might want to take that to note. But basically there's these formulas and you can predict within 8 centimeters of the actual height for the most part. So short stature, we just need to differentiate if it's genetic, is there something going on with the bones, is it a sexual developmental problem, or just how to manage this. So if it's familial short stature, it's going to be normal for the family, right? The name kind of suggests that. And their bone age is going to be normal for their age. If it's familial short stature, then their sexual development will be normal, and we can just provide some reassurance. A constitutional delay, which was that one that kind of delayed and then they went back up, it's usually a normal variant. So like I said, it could be triggered by environmental type stuff, but could also just be a normal variant. Their bone age will be delayed also. So even though they're like 12 years old, they'll look like they're 10 in their bone age, as far as those calcification sites of bone. And then their sexual development will also be delayed. So it's like, they're just kind of this late bloomer, right? So normal body proportions, we kind of want to be aware of this so that we can identify any abnormalities early on or any suspected genetic problem that we might be facing. So it's just interesting to see, like you can see here, like this kid's elbow almost, or definitely the very top of the hip is here, and then this is the lower body. And then as we get older, you can see these hips go up. Now our hip's here, and then it's there, and now it's there, and the lower body gets longer. So just kind of a cool proportionality thing. Pathologic short stature, so they can be proportionate, disproportionate, or dysmorphic. So if they're just short, they're going to be proportionate. If they're disproportionate, we'd want to investigate for skeletal. There would be, and we would investigate any if we found signs of skeletal dysplasia. And if it's dysmorphic short stature, then it's going to be either some sort of a genetic cause, trisomy 21, Turner syndrome, fetal alcohol syndrome, and other syndromes. Initially, for non-endocrine disease, we can do CBC, metabolic panel, UA, sed rate, CRP. These labs, and why these labs, you'll want to research, and we can consider malabsorption and celiac disease if we've got this disproportionate or proportionate disorder. Now, a lot of the reason that we might screen for these two guys is what? Why would we care? Well, one, we're thinking of autoimmune, and two, we may be thinking of something more insidious like cancer or infection. So, growth hormone deficiency. So now moving on to particular deficiencies in these other hormones. So we've got GH deficiency. It can be isolated, congenital, acquired, or pan-hypopituitarism. So pituitarism. So this would mean all the pituitary hormones are not produced very well, but it can be acquired, congenital, and then isolated. So if it's congenital, forms may have these mid-face deformities. This is what this is called, or abnormality. Basically, very large forehead, very larger head. Now, that's the thing that's difficult to say, is that the variation of normal is out there. You do get a lot of pediatrics that have kind of a larger looking head, and that can sometimes just indicate good brain growth. However, we want to keep an eye on this, and that's why we check the compared with the stature and the head circumference and all these things together. We want to start saying, okay, well, maybe we should just investigate this for an endocrinopathy. So Growth hormone regulation, all the regulation on these things, you just have to understand, because if you don't understand them, then you cannot properly understand what labs to order and how to treat your patient. So GH stimulated by the liver, insulin growth-like factor is the compound that's produced by the liver in stimulation by GH. And then there's these insulin growth factor binding proteins that are also in play. And the take home here is that this insulin growth factor binding protein, or insulin growth factor itself, is what we're wanting to test for GH level, because GH level itself is just not a very reliable test. It's transient, so it makes the signal and then it's gone. And so this IGF is really what we do for any concern of growth hormone abnormality. So circadian rhythm, stress, and cortisol and or fasting is going to trigger the release of GH. GH is then released by the anterior pituitary, targets the liver and other tissues. At the liver, you're going to release insulin growth-like factor that targets the growth of cartilage, also the absorption of or the production of glucose from probably non-optimal glucose sources, or from any storage forms. And then bone and tissue growth is also triggered. Then we've got this negative feedback, right? So if this is broken, if anywhere in this system is broken, then we have a problem. So let's look at this. So somatostatin is made in the posterior pituitary, but in anterior pituitary here, we've got growth hormone. So what growth hormone does is it acts in two different portions. It can act in the central portion of the brain, which would be the hypothalamic portion. This can be, if you have a central GH problem, then it can be from a hypothalamic tumor. If you have a peripheral problem, it can be from a tumor in the pancreas. So there can be GH causes that are in the brain and then in the rest of the body. If you have primary GH excess, the excess could be from a pituitary adenoma, pituitary carcinoma, an extra pituitary tumor, and then other familial syndromes. Extra pituitary GH excess can come, which we talked about, from pancreatic islet cells or a tumor there, from a lymphoma, or just iatrogenically, which means that we probably irradiated something or are giving it. So, gigantism. So gigantism is abnormal linear growth due to excess GF1 prior to closure of the epithelial cells. So they're this giant that kind of looks like a younger giant, like a baby. This kid's like 5. Just kidding. But you can see the features. He looks young, even though he's like and it's just, I think his dad's like, oh my God, I cannot keep this kid in clothes. Like, right? We say that for parents, but this dad's like, he has a complaint. He even looks annoyed. All right, so acromegaly and gigantism. So acromegaly versus gigantism. Gigantism occurs when they're young and they see this guy, he looks really young, but he's like huge because these people are kind of small. Abnormally high linear growth due to GF1 prior to epiphyseal plate closure. And then this is a disorder of GF1 after the closure. So MRI is probably going to show a pituitary tumor. Look at this. 90% of acromegaly patients have a pituitary tumor. The best test to confirm the diagnosis is the glucose suppression test. So in the presence of glucose, the growth hormone should decrease. So in acromegaly, growth hormone does not suppress growth hormone. So I just said that backwards. So in acromegaly, it's abnormal. Glucose should normally suppress this guy. He should get kicked down by these glucose structures. At any rate, when glucose is administered and GH is inappropriately being produced, then it is not inhibited. So normally glucose should cause GH to go down, but in acromegaly, glucose equals GH, no change. All right, so no change with GH in acromegaly, and there is some change with GH when you have a normal functioning pituitary. Dwarfism. So there's different types of dwarfism. First, we need to know the actual definition, which is dwarfism is defined as an adult height of 4 feet 10 inches or less. There's a few different types of dwarfism. There's disproportionate, where their proportions are not the same. And then there's also proportionate dwarfism, where they're just a smaller version of a normal scaled, or what we consider to be normal scale. Addison's disease. So Addison's disease, also known as primary hyperaldosteronism, is something that JFK suffered from. See this nice, beautiful tan. Well, the fact is, good looking dude, but the truth is that he had Addison's disease, which caused him to kind of have this copper tone to him, and that's due to the bilirubin changes secondary to this aldosterone insufficiency. So as Addison's disease, it's also called chronic adrenal insufficiency. It's a primary deficiency of cortisol and aldosterone due to atrophy of the adrenal cortex. So the adrenal cortex gets squeezed out here and won't produce these hormones. This can happen when people are taking cortisol, because that negative feedback causes the adrenals to just kind of dry up. So the diagnosis is diagnosed by this ACTH stimulation test. So you're trying to stimulate the release of ACTH, or you're seeing if it can be inhibited by cortisol. And so that's kind of the mechanism there. Treatment for this is steroid replacement for life. It's going to cause, due to the fact that aldosterone is affected, you're going to have sodium abnormalities. And in the case of Addison's, it's going to be a hyponatremia. Addison's then can be differentiated from primary hyperaldosteronism. So Addison's disease and primary hyperaldosteronism can be separated then. So Addison's is adrenal insufficiency and low aldosteronism, where primary hyperaldosteronism is the opposite. And we're talking about excess secretion of aldosterone. This is consistent with something called Conn syndrome, where you have a tumor that sits on the adrenal gland causing overproduction of aldosterone, or bilateral adrenal hyperplasia, which is these very large overactive adrenals that are producing gobs of aldosterone. Treatment for this is spironolactone, which reduces aldosterone levels and is also a potassium-sparing diuretic, so you'd want to make sure those patients are cautioned on potassium intake. But some of the problems with too much aldosterone would be that we're retaining too much fluid. We're going to lose our sodium or our potassium. We're going to retain fluid. This can lead to hypertension, low potassium, and low renin levels, as we don't have that normal feedback. I would, it's kind of out of the scope of this lecture, but I would advise that you guys go back and visit aldosterone and just some of those mechanisms so that this all makes sense. Because if you don't understand the aldosterone sodium relationship and the relationship to blood pressure and renin, and that would be the RAS. So go back and study the RAS. There's a really good YouTube video on the renin angiotensin aldosterone system. And I would do handwritten tutorials. They have a really good tutorial on that, and you'll just have that slammed in. Cushing's syndrome. So Cushing's syndrome, the etiology is excess glucocorticoids. Okay, these can come from exogenous sources. This is the most common, right? So ingesting steroids. There's also endogenous sources, so increased pituitary ACH or Cushing's disease, also known as, and rarely you can have tumors. So the presentation is they'll be obese, short stature, this moon facey, right? Too much glucocorticoids, and they get this Cushing's syndrome, right? Hypertension, striae. How does the picture differ from simple obesity? Well, this moon facey really is probably the biggest difference, I would say. All right, so moving along here. Computer's trying to freeze up. Give me just a second here. Okay, we're back in business. Okay, hypothalamic pituitary adrenal axis. So, boy, this is a lot of mechanisms, and it just kind of all blend together after a while. So the hypothalamic pituitary adrenal axis. So let's break that down. So hypothalamic to the pituitary, right? And then to the adrenals. So here you get your cortisol releasing hormone, targets the anterior lobe of the pituitary, releasing ACTH, also known as adrenocorticotropic hormone, which then goes to the adrenal gland and causes the release of cortisol. Cortisol plays a role in homeostasis, right? And also triggers the release of sugar. It also causes us to make sugar from non-sugar sources, like triggering glyconeogenesis. So tropic basically just means pertaining to, so pertaining to the adrenals in this, or it can also mean made by. So how do we diagnose Cushing's disease? Well, we could get that kind of triad of stuff, and then we would want to investigate with a 24-hour urine cortisol and or a midnight salivary cortisol. So those are two tests that we can use. There's also this test called the dexamethasone suppression test, which a dexamethasone suppression test should normally when you give dexamethasone, you should normally decrease the amount of cortisol in the body, because the body senses the dexamethasone and says, ooh, I don't need steroid. And so it decreases the normal production of cortisol. Whereas in an abnormal test, you would not respond. It would come in and you would just continue producing cortisol. You may want to watch a video on this. It's not the most clear. It's a difficult concept, and it can take 15 minutes or so to fully explain how the test works, but still was over my head. But you may want to take a look at that. If the patient is getting exogenous glucocorticoid, the test would basically show the same response. But go ahead and review that a little bit more. That test still confuses me, but I think the take home is that to diagnose Cushing's, we use this test. That's usually the scope that most of them want us to know. But for those of you who can't stand knowing that, which was me in school, I'd go back and find a video on that and just kind of soak it up a little bit more. All right, so here's a case of a abnormal weight gain. So 7-year-old with some keloid scars and had a burn, received some intra-lesional injections of the burn to try and prevent too much scarring. And these injections occurred over and over and over for 6 months. 4 months after the treatment stopped, she was evaluated for this weight gain, facial puffiness, cervical fat pad, striae, increased hair growth on her back, which is never a cool thing, especially for a 7-year-old girl. And per the HPI, this started about 2 months into the steroid treatment. So there's your case of Cushing's, iatrogenic Cushing's. So to evaluate for endocrine pathology, there's this stepwise progression. If there's this decelerated linear growth in a well-nourished or obese child, we can investigate. So if we want to investigate for hypothyroidism, we can do the T4 and T3. If we want to investigate for a growth hormone deficiency, we do our insulin growth factors. And if we want to investigate for Cushing's, then we can do the urine cortisol, the dexamethasone suppression test. And what we would see with the serum T3 and T4 would be low in a hypo, right? So they hypo, so the thyroid is just chilling and not wanting to work. And TSH is just like, come on, man, let's go to work. But nope. And so it's puny, just puny, pouring out a little tiny bit of T3 and T4, right? So in your GH bone deficiency, right, you're going to see, depending upon the deficiency, this could either be elevated or decreased. And then with Cushing's, your urine cortisol level is going to be elevated because they hypercortisolism, but the dexamethasone suppression test is going to be AB normal, all right? Here's these normal thyroid, delayed bone age, decreased IGF, right? Growth hormone therapy, so we can use recombinant growth hormone under the direction of a pediatric endocrinologist. Only if it is a true growth hormone deficiency. We also want to be mindful that there are certain situations like Turner syndrome, chronic renal disease, and idiopathic short stature that we don't want to just completely forget about. And we also need to make sure that this child has a support system, family support system. They're going to do daily somatotropin injections, which is never fun. And there is going to be a psychological impact on the fact that they have extremely short stature. Normal puberty, we can kind of look at here. There's this point where they go through this height spurt. And so this is just kind of good to know where that normal lies and that there also is variation in normal. The goal really is to determine if the variations need to be evaluated and or if the child needs to be referred. This is the hypothalamic pituitary gonadal adrenal axis. So here we go again with another feedback loop. I mean, these just like boom, boom, boom. You just can't get away from them. So here's the hypothalamus, right? This is the hypothalamic pituitary gonadal complex, right? So let's try to walk through this. So triggered by the CNS, stimulates the hypothalamus to release gonadotropin releasing hormone, which then triggers the pituitary to release LH and FSH, which then target the gonads to either, develop basically, and you're going to develop either with androgen or estrogen. And then inhibin kind of regulates this process, but it causes the development of these. And then we upregulate. As we upregulate estrogen or androgen, then we're going to deregulate the system. And so this is why these guys that inject steroid have to keep doing it usually for life, as they screw up this gonadal mechanism, and then the gonads are going to atrophy because you basically have androgen that's circulating in the body and you don't need to produce it from the gonad. So the adrenal axis, so let's try to walk through this also. So you've got the CNS stimulation to the hypothalamus. You've got, then we also are going to have cortisol releasing hormone, which then is going to target the pituitary to release adrenocorticotropic hormone, which then targets the adrenal cortex to release different compounds that then also, these androgens and DHEA, which also are controlled by androgen production. So then the negative feedback back here to the hypothalamus. So good times at those. We got to talk about pubertal delay, as we may find this in primary care. Definition is going to be for girls if there's no breast development by age 13, and then for boys if there's no testicular development by age 14. And then we use like the Tanner scale and things like that to kind of see where they are. And the etiology is sometimes a constitutional delay, which is the most common. Also can be a low gonadotropin or high gonadotropin in gonad failure. If the problem is at the testicles, there could be a chance that it's a Klinefelter syndrome, because chromosome 47, we're supposed to have 46, right? So they got one extra, and it's an XXY, which causes them to have some abnormalities in their androgen production. And then if the problem is at the ovary, then it could potentially be Turner syndrome, which is on chromosome 45 with this XO instead of a normal XX. So sexual maturity rating 2 or Tanner scale 2. This is the first physical sign of puberty. So we use that Tanner scale to kind of grade our progress. I'm not going to belabor the Tanner scale. You can look it up. It's really used by the pediatricians a lot. So when you go into your pediatric rotations, if you haven't yet, then you will really get slammed with the Tanner scale. So just know that it looks at the child's development and where they are, and it is commonly used in pediatrics. Constitutional delay of puberty. So the height of puberty may be delayed. This is the earliest indicator. Often, if it's a constitutional delay, then there's some family history. Bone age may also correspond to the height. We want to assess testosterone levels, and at sometimes, if indicated, we can use short doses of testosterone in boys to kind of kickstart the puberty. We can do screening tests just to assess for general health with the CBC metabolic panel and some thyroid studies. And we can also look at the gonadotropins. Klinefelter syndrome. So Klinefelter syndrome is that syndrome that we talked about before with the abnormal genetic makeup. And normally we won't really recognize this, but usually they kind of have this pubertal delay, and the FSH and LH in this case would be low, and the testosterone would also be low. Amenorrhea is the primary presenting complaint for females. There's a few different reasons that this could be, but to actually diagnose this, they have to be 15 years old, and they have to have started having a normal cycle 3 years ago. It's got to be at least 3 cycles, and some causes could be obviously pregnancy, immature hypothalamic pituitary gonadal axis, anorexia or stress, or polycystic ovarian syndrome. The actual definition of amenorrhea must be 3 cycles, and they must be up to 6 months if the cycles are irregular on a normal basis. So the causes of primary amenorrhea may be an imperforated hymen, which you'll see right there, and you can see on the ultrasound. So that can be detected earlier with normal exams of the genitalia. Primary amenorrhea is a normal secondary sexual characteristic. It can be autonomic or from an outflow obstruction. We need to work this up with an ultrasound. Lack of secondary sexual characteristics does indicate maybe an endocrine problem. If we look at the hormones, we can see low FSH and LH. Also, at the ovary, we may do an ultrasound, and then if we want to do blood work, you can do a karyotype. We want to think about hypothyroidism, and the presence or absence of a prolactinoma should be investigated. Turner syndrome. So Turner syndrome, which we already talked about the genetics of, pretty hard to recognize other than this low hairline and kind of this webbing at the neck. I noticed that's a little bit wider. FSH and LH are going to be low, and the estradiol is also going to be low. Actually, in this case, the FSH and LH would be, they would actually, luteinizing hormone, those would be low, and the estradiol would be low. Yeah. And so it would refer for hormone replacement. Precocious puberty just means early puberty. The definition is starting puberty before age 8 in females, and in males, it's age 9. We want to evaluate with some labs if we need to. We also want to look at those secondary sex characteristics, and we're going to Turner stage these kids. So labs for that include the gonadotropins, sex steroids like testosterone estradiol, DHEAS, and androstenedione. Central causes, we would see them all elevated. That means it's at the brain. We're going to refer or consider this, that there may be some gonadotropin releasing hormone suppression, and so we would refer. Peripherally, there's a variety of causes, typically low gonadotropins. Various steroid results may also help us try and figure out what the heck's going on. And when we're just totally confused, like 90% of this stuff, we'll send it out. Puberty variations, so they can have benign premature thelarchy, so the start might be early and there may be no abnormalities. There may be some isolated breast development. We want to do a workup and follow up on them. Gynecomastia in boys can occur normally in mid-puberty and may last a couple of years. We also want to consider exogenous sources and or Klinefelter's syndrome. Adipose is another thing that can cause excess estrogen in boys and males, so that's something to keep in mind. Pubertal variations, so isolated premature adenarche. So what's the definition of that? So pubic hair before age 6 to 7 in a girl and 9 in a boy. If normal growth and no virilization, isolated DHEA secretion from the adrenals should be suspected. We want to closely follow these kiddos, watch their height, velocity, and bone age. And with girls, 15% may develop polycystic ovarian syndrome, so that's something that we need to keep in mind. We'll consider, we'll keep it in mind that there may be some mild forms of congenital adrenal hyperplasia. So let's review the adrenals really quick. So we've got these pubertal hormones that are made in the adrenal called androgens. We've also got glucocorticoids and mineralocorticoids. And it's smart to kind of know where these are made. I don't know, they always tend to think that this is testable material. I think it's kind of not fair, but you're in PA school. So take a look at this, make sure that you know where these are made. Let's do a quick case on dehydration. So this case is a 6-day-old girl that presents with vomiting and dehydration. On physical exam, you note that she's a lethargic infant with virilized genitalia, meaning clitoral enlargement and edema of the labosacral folds and hyperpigmentation. When you do some labs, you notice that there's an acidosis with a low sodium and a high potassium. So you've got some electrolyte abnormalities. If you see this, the problem is that the adrenal glands are causing increased release of androgens and causing congenital adrenal hyperplasia. So classic congenital adrenal hyperplasia is secondary to a deficient enzyme 21 hydrolase in the adrenal cortex. Cortisol and aldosterone production decreases and or is absent, and androgen production is super increased. So you just may want to make like a little graph on this particular point with the congenital adrenal hyperplasia and just say, okay, lots of androgens, right? So then any of the symptoms that you see or read in a question on a test might gear you toward this diagnosis. So this is mostly detected in the newborn screening and usually doesn't cause any salt wasting to occur. Rarely presents later as premature starting of the menstrual cycle. So you don't need to memorize this, but it just kind of tells you how DHEA comes from cholesterol. We need to be thoughtful about this when we're prescribing statins, as these cholesterol is a precursor for all of these other compounds. And so we really need to be careful if we're ubiquitously giving statins, because we're watching this small fraction of science about cardiac, which is great. We should definitely keep lipids down. But if we just ubiquitously drop statin in somebody, we could bring down their cholesterol levels and they won't make any of these hormones. So how is congenital adrenal hyperplasia treated? It's treated with glucocorticoid replacement in the form of hydrocortisone. This is daily and can be increased in times of stress, as the body will need more, like illness and surgery. Mineralocorticoid replacement can also be performed, and this is daily if there's any salt wasting. So if they're losing salt secondary to impaired aldosterone production, then we will definitely need to make sure that we are using this fludrocortisone and monitor the electrolytes. So back to our case of the 6-day-old, they basically need hydrocortisone. All right, let's review glucose regulation. So glucose regulation, you should be really, really comfortable with this. You got alpha cells and beta cells in the pancreas, which both do different things. The alpha cells produce glucagon and the beta cells produce insulin. So the trigger here is high blood sugar, causes the pancreas to release insulin. That causes cells to uptake glucose and then process the glucose, which lowers blood sugar. If glucagon is then released from the pancreas, it's going to stimulate the breakdown of glycogen, and then you're also going to release glucose into the system as the glycogen is broken down. So this mechanism really needs to be understood well, and then the nuances of it, and when DKA is involved, it gets way more complicated. Diabetes type 1. So diabetes type 1 is an autoimmune problem. It's caused by the destruction of the beta cells, which produce insulin, and then you don't make insulin. So then your cells don't use insulin, and then the cells can't use glucose for energy. So boys and girls have an equal opportunity to be affected with diabetes 1, and this is going to peak at 4 to 6 years of age. The incidence in Scandinavia and is highest and lowest in China. Genetic predisposition, certain HLA types may increase the risk, as well as family history, and then plus or minus genetic factors. So let's go to a case here. You get a 3-year-old that presents with abdominal pain, has vomited twice, appears well, but mom has noticed unusual thirstiness in the past few days. And I would also tell you that this 3-year-old is probably peeing a lot and filling up a lot of either diapers or toilet. Second case is a 5-year-old with 3-day progressive abdominal pain, drinking a lot of fluid, polydipsia, new onset enuresis, wetting the bed, and 2-week history of weight loss. That is diabetes until proven otherwise. But in reality, there's more to the story. There's a tachypnea with Kussmaul breathing and moderate dehydration. So what's going on there? This patient you want to identify quickly as a diabetic ketoacidosis. When you have an acidosis, you have increased acid in the blood. And a lot of things can happen here. You guys have to understand this. So when someone is not responding to sugar, they're not using sugar for energy because their body doesn't have insulin to bring the sugar into the cell. Insulin is what causes glucose to be put into the cell, right? And so if the insulin's low, the glucose builds up and builds up and builds up. And triggers the body then to go to the liver, where at the liver, the body is then going to use non-optimal sources to produce glyconeogenesis from fat, and as a waste product is going to create ketone bodies, which cause increased hydrogen ion concentration. And an increased hydrogen ion concentration within the body is going to do what to the pH? It's going to lower their pH. Once that pH is lower, the body doesn't like that. And so what the body starts to do is take potassium out of the cell, which is primarily intracellular, and exchange it for hydrogen to try to buffer the pH. Now these potassium go out. So anytime you're in DKA, you get a very elevated potassium level. You're also going to trigger osmotic diuresis because you're diuresing this glucose in an attempt to control your blood sugar levels. And in an attempt to control this pH, you're also doing Kussmaul breathing. And the reason why you're doing Kussmaul breathing is that CO2, by nature in the blood in the form of bicarbonate or carbonic acid, once it picks up another carbon, needs to get blown off to help decrease the pH. You should think of CO2 as an acid. So as these people breathe faster and faster and faster, it's an attempt to decrease their, or to increase their pH by decreasing their CO2 level. So that's a nutshell. That's a very big, large nutshell of DKA. So type 1 diabetes is this trifecta of polyuria, polydipsia, and weight loss. And that's diabetes type 1, also diabetes type 2, really. And may also present with abdominal pain, nausea, vomiting, pancreatitis, persistent vomiting, headache, if they have persistent headache, vomiting, altered mental status, and hypertension, they're definitely in DKA. You don't want to miss that dehydrated infant or toddler with the heavy diaper and no diarrhea. That is a sign of DKA. Are they still in there? Okay, let's take a little break and then we will power on to the end. We got about 30 slides to go. Okay, so here's DKA simplified, which we kind of belabored earlier, but basically, you know, triggered normally almost always by stress. So that's why we always want to think when we see someone who's in DKA, that there's a strong chance that there's an infection at work, mostly secondary to that. This stress response, so the increase in cortisol and catecholamines due to stress causes increased glycogen to be broken down for glucose, which increases glucose, and then they osmotically diurese to try to urinate off the glucose, and that screws up their electrolytes, plus that potassium shift that we talked about earlier. And then when you've got cortisol and catecholamines, it's triggering you to use lipids as a non-glucose fuel source, which increases the fatty acids, which increases the ketone bodies, which are a negatively charged, actually a positively charged, but a hydrogen ion, which increase the acid in the body and will cause an acidosis. So new onset, you know, they're going to be an inpatient in ICU if they didn't even know they had it, and all of a sudden they're in diabetic ketoacidosis. We're going to have to slowly get their electrolytes back on track, slowly correct everything. We don't want to give bicarb as it can cause more problems than good, particularly with cardiac arrhythmia. And we'll gradually correct this hyperglycemia. Some texts will say between 200 and 250 or less than 200. Then you add IV glucose because you don't want to bottom them out too much when you're giving insulin. We're going to watch our electrolytes, particularly sodium and potassium. Remember that there's a corrected sodium calculation if their glucose is greater than 300, that will correct the sodium, as it could be falsely low. So you don't ever want to replace that until you confirm it. And then once they're stable, they can be switched to some Q. Insulin in children, these insulin pumps are nice because they don't have to poke themselves. We definitely want to get a pediatric endocrinologist on board, and they may utilize an insulin pump. Principles of management are to maintain normal glucose, right? Decrease sequelae like retinopathy, renal disease, or nephropathy. And these very low blood sugars we need to be careful with can damage the brain. So we want to target blood sugar and watch the A1C. Here's some A1C levels. Once they're daily and at home, we're going to check this blood sugar. And if it's greater than 300, we want to check for urine ketones. Recognize any signs of hypoglycemia. And then also in 2014, continuous glucose monitoring was approved for 2-year-olds, but less reliable than in adults. And another thing we can do is help with carb counting. We can make sure that they're selecting foods that are low on the glycemic index, and then good snack planning as well. All pediatric type 1 diabetes mellitus patients should see a team of people, including an endocrinologist, dietitian, and educator. However, that's not always reasonable, especially for some certain demographic areas. And they should definitely have a primary care provider, which would make sense. We need to understand that it's a long-term plan. We want to make sure that the family is providing open lines of communication with the school, camps, and sports. Okay, diabetes mellitus type 2 can cause peripheral insulin resistance to the tissues surrounding. can cause a failure of the pancreas, secondary to autoantibodies, to secrete insulin as well. These are some of the clinical manifestations. All right, type 2 diabetes mellitus. Possible to have autoantibodies, but not as likely, and possible to go into DKA, but more likely to have HHS. Diagnosis of either type of diabetes mellitus is based on a fasting blood glucose greater than 126, a random blood glucose greater than 200, and a 2-hour oral glucose tolerance test greater than 200. If their hemoglobin A1C is greater than 6.5, that is also diagnostic criteria. If we're in doubt, we can double check insulin. D. All right, diabetes type 2. Risk factors include obesity, family history, diet, and activity, ethnicity, particularly in the US, Native American population, Hispanic American population, African American population. Associated conditions include hypertension, dyslipidemia, polycystic ovarian syndrome, diabetic, or an infant with a diabetic mother. Screening of high-risk children at age 10 or onset of puberty, whichever is earlier. Screen children who are either obese over the 85th percentile or have 2 other risk factors such as family history, high-risk race or ethnicity, condition associated with type 2 diabetes, or maternal gestational diabetes. The treatment for type 2 diabetes is usually family-centered. Nutrition, they should work with a dietitian, they should exercise, and they should be able to hopefully reach this with some conservative measures. Less than or equal to 10% of the pediatric population reach their blood glucose goal with lifestyle interventions alone. So about 1 in 10 will do that, but that takes a lot of work. Initially, we can start these people on metformin. Metformin, we need to know, has the risk of GI upset and or diarrhea. So we'll start low and slow and kind of slowly progress. We'll start with 500 milligrams daily and then increase. There's also the extended release metformin, which tends to be tolerated a little bit better. Case of a seizure. So we've got a quick case here on seizure. 4-year-old boy with mild respiratory symptoms a few days ago. Today is more tired and in the past hour has become less alert, pale, cool, clammy, and then had a generalized seizure. He's stabilized with ABCs and has a finger stick of 38. So what triggered the seizure? The hypoglycemia. So how do we treat this emergently? Well, we need to stabilize this patient first. So airway, breathing, and circulation. And then we need to do a urinalysis and blood sample to see where we're at with electrolytes and what interventions need to be undertook. We're always going to consider that this was exacerbated by an infection. It can also be from endocrine abnormality, Munchausen by proxy, where somebody's giving their self-insulin. I actually found this in a patient. Alcoholism or other metabolic disorders. In the neonates, this can be transient, as their mother may produce lots of insulin, and as they get used to that insulin, if they are then born and it takes some time for their body to produce insulin, their blood sugar can drop greatly, or they can have insulin, their mother's insulin in their bloodstream, and then they're born and their blood sugar drops greatly. And they don't have sugar produced by the mother, and they can't do glyconeogenesis because they're having an immature liver, so there's a lot of reasons behind that. If they're known type 1 diabetes mellitus, that's another cause, right? Symptoms can be illness or signs, increased illness, altered sensitivity, equipment malfunction, or abnormal counter-regulatory hormones can all trigger this. We're going to treat this with oral glucose glucose, and if severe, then glucagon. If it's unexplained, we want to figure it out, right? This would be called, there's also something called idiopathic ketotic hypoglycemia, commonly found in children, triggered by fasting and often during an illness like some sort of gastroenteritis type bug or more of a chronic illness. The management is frequent small meals containing protein and carbohydrates, and it usually remits by age 8 to 9. This is a diagnosis of exclusion. You should exclude sepsis and rare endocrine metabolic disorders before you just automatically assume that it's just idiopathic hypoglycemia, as that does not occur all that often. We want to find out if they have or do not have ketones. This gives us an idea of what they're using for energy. We also want to get a glucose level and insulin level. We want to check on their ketones in the serum as well as in the urine and get a lactate on these patients. If the past medical history is negative, so this is back to our case. So past medical history is negative. While starting, the IV and blood samples are obtained, and before giving IV glucose bolus, a straight cath is performed for urine sample. In addition to labs just discussed to evaluate the etiology of hypoglycemia, what else might you order? So what other things can you think of for this patient that you could potentially order to start investigating, right? So you could check some of those endocrine levels. You could also, I would basically do a full workup on this patient, including bleeding time and liver pathology. So it's pretty fair workup. I'd also want to look for infection, right? We want to look for a cause to this, like the fact that you need to screen for an infectious process, like a chest x-ray and urinalysis. So diabetes insipidus, moving on. So what is diabetes insipidus? Well, diabetes insipidus is wrongly named. It has nothing to do with diabetes. The kidneys filter blood and excrete a small amount of urine. In diabetes insipidus, the filtrate is greatly increased, and it's secondary to a central or a nephrotic cause of ADH abnormalities. So if it's a central cause, then we're not producing antidiuretic hormone. That can be caused by like a head injury or some other brain abnormality. And then if it's a nephrogenic problem, then there's no response to antidiuretic hormone in the renal system. So they call it diabetes insipidus. It does kind of present like diabetes, but it's not. So it's actually an ADH problem. So normally, right, we drink water. The pituitary gland says, hey, why don't you keep some of that water instead of just peeing it all out? And it concentrates it quite a bit more and keeps our body hydrated. In diabetes insipidus, the pituitary gland doesn't work the same and doesn't make enough or respond to ADH, causing very dilute urine. So the urine specific gravity is like 1.00000001, and then you would have a high suspicion of that. So we would want to find out if this pituitary disorder was either central or nephrogenic. So central causes can be genetic, can be from a head injury, an infection, an autoantibody, can be from loss of blood supply to the pituitary, so severe blood loss. Could be from surgery in the area of the pituitary or from a tumor. Nephrogenic causes, so now we're talking about renal causes, are very rare, can be due to certain medications, lithium being a big one, can be secondary to genetic problems. There can also be a high level of calcium in the body, hypercalcemia as a nephrogenic cause, and then kidney disease such as polycystic kidney disease can also cause a nephrogenic diabetes insipidus. A pituitary adenoma. So a pituitary adenoma is a mass here in the pituitary gland. Actually had a gentleman that ended up having one in the emergency department. He was complaining of headaches that awoke him at night, and that it was the worst headache of his life. And he was a young 22-year-old African-American guy that was in very great shape and really had no other health problems in it. And I did a CT on him just to make sure, because he thought he just had a migraine, and it turned out to be a pituitary tumor. So don't blow those people off. Sometimes they don't even know that they're giving you the story of a tumor. You know, he just thought, oh my gosh, I had this terrible headache that woke me up at night and it won't go away. And it's the worst headache I've ever had. And it did really turn out to be a tumor. So I really hope and pray that that gentleman is doing well, because he was a super nice guy. And he was very, very young. So at any rate, signs and symptoms can include vision changes, as this is close to the optic chiasm. So we want to assess for vision changes. Do the headache rules, right? Is this the worst headache of your life? Was it maximal in onset? Was it acute in onset? And then another one kind of on the back burner there is, did it wake you from sleep? Some cases can be can cause hormonal abnormalities, which can interfere with menstrual cycles or cause sexual dysfunction. So that's kind of some probing you can do when you talk to the patient. Non-cancerous tumors will not metastasize, so it should just be in one location. The treatments include surgery, medications to block hormone production, which can shrink the tumor, and then in some cases they'll use radiation. Calcium. So calcium homeostasis is regulated by the endocrine system, and it is daunting when you look at it, because you're just like, oh yeah, it's just calcium. Well, boy, it's a pain in the booty to kind of understand, because there's a lot of systems that are involved. But one thing that we should know about calcium is that 50% of the calcium that we use is in the form of Ca2+, which is actually considered ionized. And this is the active form. The other 40% is bound to albumin. And what most people don't realize is when you do a CMP, the analyzers that they use to do a CMP only measure bound albumin to calcium. So if there's actually an abnormality, we need to investigate what the free calcium is, because that's really what matters. And then there's kind of this 10% that sits in this ionic complex called citrate, and we don't really care. But let's try to navigate this. So where the heck do we even start here? They say, let's start. No place looks better than the other. So let's start at the kidney here. Oh, here we go. Let's start at the parathyroid gland. That's probably the best. So the parathyroid gland is going to monitor calcium levels, and when those levels fall, then it's going to create a signal. This parathyroid hormone then targets bone and stimulates osteoclasts to break down bone and release this calcium to the bloodstream. Also targets the kidney to reuptake more calcium, and indirectly targets the bowel to also retain more calcium. And then here we go to the blood levels. Obviously, this is now going into the bloodstream. The blood levels are going to go up. And then here, once we get to about this level, then it reaches homeostasis, and we don't have to make any more of these changes. If there's a stimulus, which causes calcium levels to rise, then the thyroid gland releases calcitonin. So the thyroid gland notices that there's this stimulus, and that then triggers calcitonin to be released by the thyroid gland, which then tones the bone, stimulates deposition, so increased activity of osteoclasts to degrade the bone, causing an increase in calcium levels, and then that will be reduced, and then that goes to the kidney as well. The same calcitonin is going to trigger the kidney to excrete less calcium, and then reduces uptake. So you can stimulate the kidney. Oh, this is the opposite. I'm sorry. Oof, I got it all off. I'm like, what the heck is going on? Okay, so I've got myself and you all screwed up. So let's walk through this again. I apologize. So this is your negative feedback. So calcium levels normal. It's going to cause calcitonin to be released at the thyroid. Calcitonin tones the bone. So that causes the osteoblast to upregulate, causing bone laydown. So you're actually laying potassium down and then slowing the loss of calcium at the kidney. So calcitonin causes retention of calcium and calcium deposition into the bones and the blood level. And it goes and goes and goes. So those are so easy to get tied up in. I mean, I've walked through these so many times and I still get hung up on them. So just bear with it. You'll get it. Hypocalcemia. So hypocalcemia is usually transient in neonates unless they're stressed. In adults and children, can be acute due to illnesses, which is the most common, and stress. Can be chronic and related to the parathyroid hormone level. An insufficiently circulating amount of parathyroid hormone is considered hypoparathyroidism. Insufficient responsiveness to that level is pseudo-hypoparathyroidism. We always want to get a vitamin D level on these patients because the metabolism is very interrelated. Hypocalcemia manifestations. So you've got the cheek sign here. You tap on the cheek and you get tetany because they have such a low calcium level. That's called the Ches-Fox sign. And then the other true sign here in the hand is the Trousseau sign, where you put a sphygmomanometer on there and blow it up, and then the hand flexes. If they've got chronic poor bone mineralization, that is consistent with rickets. If we want to diagnose this, we want to diagnose this with which lab test? Well, first we're going to get a serum calcium, but we're also going to get that ionized calcium. And this isn't always done because it has to be done on whole blood and it has to be done on a blood gas analyzer. So not all labs have that and not all providers know that. Labs to do if you've got a suspected parathyroid hormone disorder: ionized calcium, phosphate, alk-phos, phtase, parathyroid hormone, magnesium, albumin. The very best test to assess vitamin D levels is, you should know the answer to this. So you've got a few of them, but primarily we like the vitamin D 25. We'll talk a little bit more about those too. So here's this much more simplified than the last one I went through. So you're regulating your calcium levels. If the calcium level gets low, then it's going to trigger the parathyroid gland to stimulate the bowel to maintain calcium or retain more, to the kidney to retain more calcium, and to increase bone breakdown. That calcium level rises, causes the thyroid gland to produce calcitonin, which tones the bone, causing calcium to be deposited in the bone, causing the bowel to stop increasing its secretion of calcium, and also causing the kidney to decrease retention of calcium. Hypocalcemia treatment. You can give IV calcium gluconate. You want to give it slowly because it can be toxic to the veins. Also, this happens in acute illness as the stores are used up. And in chronic illness, this vitamin D1 25 vitamin D supplementation is usually indicated. And that is all. endocrine is a really, really heavy lecture. I think you guys did great. Because I have no idea how you did, because I am talking to a screen by myself. Otherwise, I hope you'll do great. Send me any questions that you have, and I will post this lecture and then also a study guide.